I would like at this point to welcome the panelists. So Jeff Fox. Jeff is, it turns out he's a great friend of mine. We did our residency training at the University of Washington together, and this is my first time seeing him in probably about almost 20 years. So he's lost a little bit of hair, and his hair's changed a little bit of color since the last time I saw him, but he still looks good.
Keep going, keep going.
He lost weight, though. And then we have Dan Lee from Kaiser Permanente, who's already given a talk. We got Scott Kawada, who is the chairman of medicine at the University of Hawaii, and then Bi-Chin Wu, who has been giving some very interesting comments from Southern California, Kaiser Permanente. So you'll notice this group is very heavy on Kaiser Permanente, and I think that Dan did a great job kind of showing everyone what Kaiser is. The initial intent of this panel was to really help them come up with a protocol for gastric cancer screening, both primary and secondary prevention. And because we think that Kaiser is just uniquely situated and is a nice closed system with a great EHR, great resources, very much research-oriented, outcomes-oriented, that this is the one place everybody says we need prospective data, randomized control data, and we felt that Kaiser was probably the best situated position to do this type of clinical research to at least get us some preliminary data so that we don't have to say, oh, there's no data. And we've been working with Dan very closely, and Dan obviously has been doing this for quite some time. And literally last week, Dan goes, I got great news. I just got the pilot study approved. And so it's like, oh, we don't need the panel now. But actually, so what we're going to do right now is I'm going to give Dan the opportunity to present his pilot study and what was approved, and then to start a discussion, in part just to make sure that he's got the resources that he needs, and that whether or not we can provide him with some additional input, and then figure out if there's a way that we as in not people as part of Kaiser can also participate in this and help to grow this. So Dan, why don't you go ahead and kick it off by presenting your trial.
Thank you, Juha. So just want to thank Dr. Michael Kim this morning for the very compelling story about your personal experience fighting gastric cancer. And I know in the U.S. it takes many steps to move the needle. And we have to do something to gather data and prospectively. So I want to talk about a very simple proposal. It's a prospective pilot study for the opportunistic screening for gastric cancer in high-risk individuals. So just like very briefly talk about the evidence, contrast in evidence between East Asia. I'm talking about Japan and South Korea. Both have like a national screening program for gastric cancer and versus United States. You can see that in East Asia they have, this organized screening program for gastric cancer. And population-based, they have large observational studies to show the outcome. They already have showed outcome that gastric cancer screening improve the detection of early-stage gastric cancer and also mortality benefit. But in the U.S., in contrast, you can see we have no screening program. We have no trials, no large studies on gastric cancer screening, also no data in terms of the outcome of gastric cancer screening. But we do know that, based on previous data, that we have a very heterogeneous population in the U.S. The risk among certain populations, especially the first-generation immigrants from high-incident countries, have high risk. And also, based on the studies by Sheldon and colleagues, and we know that if endoscopy is bundled with colonoscopy, starting at age 45 to 50 for high-risk people, that might be cost-effective to do. So based on those in the data, and also I'm just showing again, showed us study in gastro in 2020 that East Asians have very highest risk of gastric cancer in U.S. populations. So we just based on all those information, also Kaiser situations, that we have a very diverse population in our member population. We have about 22%. Asians, 20% member being Asians, and also about 18% of members are born outside the U.S. So this is really a good setting for us to study this to take the first step. So we want to evaluate the feasibility of opportunistic screening for gastric cancer in our high-risk individuals by adding endoscopy to a scheduled screening or FIT positive colonoscopy. We want to evaluate the logistics of this approach because we want to know whether it's possible to implement this in a very busy GI practices. Is that possible? Because we're so fast-paced in our schedule. And on daily basis. And also, what's the uptake? If you want to invite patients to screen, do they want to do a screening? Any barriers? And we also want to evaluate the prevalence of pre-malignant gastric lesions among screened individuals, and also to assess the impact of screening on subsequent care. To be honest, I don't think we're going to find a cancer in a very small number of patients, but we want to know whether it's going to change the subsequent surveillance schedule, and also what's the chance of finding some dysplasia we can remove to remove the risk of gastric cancer down the road. So this is just a design of study. It's going to be a prospective pilot study. We start with a single center in our center, Santa Clara Kaiser, and we're going to include people who are first-generation immigrants from East Asia just to be feasible to start with, and who are due for their screening colonoscopy or FIT positive colonoscopy. And we're going to exclude people who have history of gastric cancer or history of hereditary GI cancer syndrome, or they have history of endoscopy, or history of gastric surgery. So I have to mention that at Kaiser, even we're a prepaid system, there's still different plans because we have a lot of members who have high premium, low copay, and others have high copay and low premium. So they may have a very substantial out-of-pocket payments for the endoscopy. That's probably a barrier. And so in terms of study process, we're going to identify first-generation immigrants from East Asia, say China, Japan, Korea, Taiwan, Hong Kong, by their name and chart review, who are 50 years or older and who are due for their screening colonoscopy or had a recent positive FIT test and due for colonoscopy. And we're going to send a secure message to the patient to invite them to have a screening colonoscopy, a screening endoscopy at the time of screening colonoscopy. And we have to confirm their country of birth to make sure they're really high from East Asia, because if you find a person, a Caucasian female who is married to a Asian male, by the change of last name, you're going to find the wrong patient. So you have to really confirm their country of birth, and then also the benefits and risks for endoscopy. And also you have to make sure the patient is aware that they may have to pay some out-of-pocket payments expense based on their plan. They have to know this in advance, and if they consent, then we proceed with the scheduling endoscopy with colonoscopy. And we're going to use the standardized the protocol to take biopsies at time of endoscopy, taking biopsy from the body and entering into urine, and also place the specimen in different bottles. And also if we see additional suspicious lesions, we're going to take the biopsy from that area and put in separate bottles. So the outcomes, the first one is the uptake of screening. So what's the percentage of patients who were screened versus invited to screen? And also we'll look for, we'll measure the prevalence of H. pylori among screened population or members, and a prevalence of intestinal metaplasia, focal versus extensive. And also we try to do, if possible, to do subtyping within this small cohort. I think we can do it. And it's going to be done by a GI pathologist in our center. And then we're going to measure the prevalence of dysplasia. We're also going to measure the average time of procedure, because if it's very long, it may not be that feasible to do. But I think it's going to be doable, because we know if we do a 7-minute procedure or 10 minutes, it's probably still very feasible to do. And also we're going to measure the out of events. Of course, there are really a lot of limitations in this small pilot, because this is just a proof of concept study. It's very small sample size. And definitely there's a selection bias, because you're actually only involved individuals who are due for the colonoscopy and for this screen for gastric cancer. And also if they have, say, already had FIT test negative, they won't get a chance of getting endoscopy because they're not going to have a colonoscopy. There's definitely a selection bias issue. And also the cost share for endoscopy could be a barrier to screening. And also at the first step, only East Asian screen in this small pilot. So we're going to see what we're going to find. It's definitely not a perfect study, but something we should to start with as a first step. This is just a flow diagram summarizing what I talked about, and happy to discuss with the audience. Thank you very much.
Thank you very much, Dan, for that presentation, this protocol, and your efforts in trying to get this. I know that this is not easy, but let's go ahead and open this up for discussion. And I'll start. And again, I see why it's a pilot study. Ideally, it would be nice. There's a couple opportunities here, I think, and maybe run this a little bit by Jeff too, because not knowing the Kaiser system. But what's the possibility of getting Kaiser to waive the copay? Right? I mean, it's just it's an endoscopy again, because we're not asking for everybody. It's a small pilot. And it would actually even be more interesting to have two arms, one where it's waived and one where it isn't, and seeing what the uptake is in terms of whether or not they're going to do it. Because I do see that being a potential barrier. It may not, with adequate education, it might not be a barrier because they'll say, yes, I very much want the upper endoscopy. But what are your thoughts on that? I mean, are there any potential mechanisms to allow for that?
Yeah. Yes, there are mechanisms. It's definitely a really complicated process because KP is an enormous organization, and as most of you probably know, the probably one of the reasons why KP might be such a great opportunity to do like screening things like we're talking about targeted H. pylori screening is the payer and the healthcare delivery on the same side of things. So there is a dialogue about all of these things, including which things should be covered. It often mirrors the outside world. It isn't like just a monolith, and especially costly things like starting a screening program. It really is like a lot of pros and cons are weighed. But, the more compelling the guidelines are to do something, so like today's session just like informed me more, but it would be very useful to have those guidelines, as explicit as possible about the value of these things so that we can use them to advocate for things like waiving copays. But I mean, you had the anecdote about how you're able for that one patient to do that when he was getting a $5,000 and you're able to waive it down. But KP's like
and that was retrospective.
hundreds of thousands of people.
Well, so yeah, that's the thing. We're not looking at hundreds of thousands of people. What's your approved pilot study size, Dan?
We didn't really mention the exact size. It's going to be small. Probably going to be like, I would say we did a little very simple power calculation. I think we need at least 43 patients to tell the difference in terms of GIM. And I think going to be maybe 50 or 100 to start with. It depends on our bandwidth. I may include or invite another one or two gastroenterologists who are interested in joining me. So we'll see how it goes.
Chen.
Yeah, no, this is great stuff. Appreciate you guys actually doing something. So, I understand you're going for small numbers, but I'm just wondering why, just even as consensus building or whatever, that you're limiting to just East Asians. I understand there's some benefits to that, but like, for example, even if this is based in Santa Clara, the Vietnamese population, which has pretty high rates, so just something to consider, I guess. I mean, it sounds like this is already in play, as well as, I don't know if Doug's still here, as well as people from the C4 region of Central America. It gets complicated, I understand that, with Spanish, et cetera.
We just think this is going to be very easy to start with. That's why there's no set plan. I think we definitely can expand the population. It has, Vietnamese definitely higher risk, so it can be included. But I would say I would probably not start with Asian plus Hispanic and Blacks. It would be too complex to start with.
John.
Dr. Lee, is there a way in a closed system like Kaiser to find out what percentage of patients need to be positive early, so that it seems like you would save a lot of money in a closed system versus at the end of gastric cancer care, where chemotherapy, immunotherapy, all of that surgery is very, very expensive. So there must be a way, I don't know how to do the mathematics, but in a closed system, would you be able to figure out like 100,000 patients, if you screened everyone in the health, and you found like 20% gastric cancer early, you would save a lot of money.
Can I speak to that? I'm old enough. I think I'm the only one with white hair on this, or a lot of white
I
hair.
dye my hair. No, just kidding. I don't.
But, the same argument came up with colon cancer screening. And, the insurance companies at the time were looking at actuarial analyses and how much of their clientele would turn over in a year. They did not see that the investment in colon cancer screening at that time was any better than taking care of cancer patients, colon cancer when it arose in their patients. Yeah.
I'm not sure whether I catch that question correctly, but basically you're asking whether we can capture the early stage gastric cancer effectively.
And actually, maybe model the cost effectiveness of this within your system, with your costs.
That's. I have to ask Shelja for expertise in how to do this in our
Phone a
system.
friend.
I would say that in our model, it was the cost savings that were associated with preventing an advanced stage diagnosis thank you, that really drove the model. And so I think it wouldn't be that challenging. And all the cost inputs were, of course, from like CMS data, publicly available data. And so it would be the same exact thing, just kind of looking at, costs are going to be lower in a closed system from there. But that really was the biggest driver. And then also like in the sensitivity analyses, just the prevalence of the condition, so prevalence of intestinal metaplasia, dysplasia, and the rate of progression. But from a cost standpoint, it really was the end-of-life care.
So it probably should be very similar to what they did outside Kaiser. It's doable, I think. Yeah.
John.
Yeah, this is this is a great step. I mean, that's you got to the journey of 1,000 miles first step. This is wonderful. So this is a single-arm, non-randomized pilot study, correct? So, and one of the things you're going to look at, let's say, is adherence. We talked about that. I think that's huge. I think it's plagued a lot of these very large screening trials is uptake, anywhere from the colon cancer with the Nordic trial and these other trials. So you'll have a good estimate of what's going on there. One of the things we talked a lot about quality, right? And so I'm curious whether the unit of assessment is actually the patient or the endoscopist, because the endoscopist have a lot of variation in the detection of these things, which are going to be not just IM but dysplasia. And so again, pilot study, but the question is, how are you going to figure out how much variation is by endoscopists? And I was curious why you picked Santa Clara. Is that where a lot of endoscopists know what the heck they're doing?
That's where he is.
That's what I'm saying. I mean,
to be
you
honest,
can train a group, and is that why you're? I mean, that's probably why.
I'm going to be the
Clara,
person
right?
who does endoscopies. I mean, so I think because I know how to find a GIM, I'll start with the process myself. Right. And then I'll train my colleagues how to do endoscopy with finding IGIMs, looking for GIMs. And then we're probably going to only invite a couple of gastroenterologists who are interested, who have expertise with identifying GIM, just to show the real, I would say, prevalence of the lesions without missing them in the first step.
Yeah. Okay.
Yeah, I think it'll be important for you to specifically state your quality indicators for a high quality examination ahead of time. Perhaps document your examination time as well. Beechin, you should ask Beechin to join you.
Well, I just wanted to comment about what's happening in Southern California. And first to note that even though it's Kaiser Permanente, Northern and Southern California are actually different entities. So each of the different regions is a different entity. And so we did something similar. We piloted with individuals who had a first-degree relative family history. We invited them in, pilot study, to come get screened, just straight endoscopy, not a combined. Who would come in? We had the list of who had a first-degree family member, high rate of uptake. And we reached out to about 80. We got 60 to come in. Right, and we found there was a 40% of GIM rate, that there were 4 who had dysplasia. So, but it was a 60-patient study, and so we presented this to our regional GI chiefs. And so what that opened the door was not that let's do a large-scale randomized controlled trial, but that we should consider this, right? If there's a member who has a family history, let's bring them for endoscopy. It does not have to be bundled with a colonoscopy. Actually, in our system, our endoscopists prefer to just have a straight EGD session versus a straight colonoscopy session. It's just the way that the schedules are made and the staff is assigned. So that's something, and this is where the guidelines really make a difference. That really having the ACG, AGA stipulate that it's reasonable to screen patients who have high risk, then that gives our providers cover to really pursue this. But within Kaiser Permanente, there are different layers of screening. So what I would say we have right now is a passive screening, saying that if the member is interested, if the physician believes it's indicated, we can move forward. It's individualized. But as we've seen from some of the studies at City of Hope, and what we see is that if it's just offered, that's not enough. Really, patients are not coming in of their own volition. And so it's really when we're most successful is when we have those population care management systems in place. That's how we're able to achieve colorectal rates at 80% plus, is because we have a whole team of case managers reaching out to every single member. And we're not there for gastric cancer, but we are at a point where I think it's more open, there's more acceptability to this. And when we look at this, which is a little bit concerning to me, is that some of it very much so is provider dependent. So if you have an Asian American endoscopist, they're doing more Sydney protocol. If you have a female endoscopist, they're doing more Sydney protocols. And these are independent factors. So it troubles me to think that the same patient, depending on who you go to see, your treatment is going to vary. And that's the state of affairs. I think that's where we need to make a lot of progress.
But I have a question. So when did that study? It was a great study published about 2 years ago.
Yeah.
Did you have an issue about cost sharing, or who paid the endoscopy?
So we informed the patients up front. Now they had first degree relatives, so they were very motivated to come in, and that was not an issue. We disclosed that there would be a copay, and for the most part, that was not a disincentive to pursue the endoscopy. Now we did something very similar with H. pylori, where we gauged interest in getting screened for H. pylori. These were asymptomatic patients, and overwhelmingly there was interest. But when it came time, we mailed them the test. How many actually completed it? It was about half. So, even if you think, oh, it's a less invasive test, the follow-through, there's a lot of work to be done on that side as well.
So I want to pose a question to Scott. One might ask, what is Scott Kawada doing on this with 3 Kaisers? Scott's in a very unique situation, and he's in a physically closed system, being on an island of Oahu. So, Scott, what are your thoughts? I mean, and also one of the big reasons to invite Scott here is Hawaii has a very large Asian population, and they probably have the highest per capita rate of gastric cancer in the country, right? So
Pretty
Scott,
close.
yeah,
Next to Southern California, I think.
yeah. So what's your perspective in a relatively high incidence region in the United States with a high Asian population? What's your current approach, and do you feel that some form of endoscopic screening is warranted?
Yeah, no, those are great questions. So first of all, we've talked about this amongst the gastroenterologists there for many years now. And basically any Asian who's symptomatic, especially if they're first or second generation, we will do an endoscopy at the drop of a hat, right, to look at them. What we haven't done is looked at Helicobacter pylori screening. And I'm guessing from the great talks that we've heard, that's going to happen at a younger age in these individuals to catch them, before or when they're starting to develop atrophic gastritis and intestinal metaplasia. Unfortunately, no favor was done. We were talking about this offline between sessions. They've taken away the Helicobacter titers from us. We can't order them. And that's really unfortunate because that's a very important risk stratification tool. We could perhaps eliminate a number of screening endoscopies if we knew who was negative in that group. That's not to say there's not other causes of gastric cancer, of course. Hawaii right now, Kaiser has a fairly big presence, about 18 to 20% of the payer population. But the vast majority, over 50%, I would say 60 to 70% of the privately insured population is Blue Cross Blue Shield. Asians are not a minority there. We're about 2/3 of the population right now. One thought that I had, and this is a little bit sensitive because it may sound like trying to play the race card, but if your study is successful, you showed a slide, your Asian population or membership in your Kaiser program is substantial. And so if this works, is that something that either indirectly through word of mouth is going to spread to the Asians? Hey, Kaiser has a gastric cancer screening plan. And will that in turn, spur some competition with the other payers?
Well, I think at least if we show something that's really impactful, that's going to move the needle towards the right direction. I think it's going to, even there's any competition, I think it's a good thing if we can screen more patients for gastric cancer.
Yeah, I'm actually really glad you brought that up because I think we've had some success in other areas with cancer screening with targeting different ethnicities that are at risk with colorectal cancer. 5 or 6 years ago, there was a pretty substantial differential in colon cancer death rate between blacks, Latinos, and Asians and non-Hispanic whites. And through targeted screening, communications, culturally sensitive, they were able to remove the disparities entirely just in 5 years, so that the mortality rate was the same in all 4 ethnicities. And if we can do that for colorectal cancer, which actually has a lot just more volume, we should be able to also tackle this problem, I think, even if it does involve, well, actually, we know the groups that are at higher risk, so it arguably should be easier to target.
Yes. Constanza.
Thank you. Constanza Camargo from NCI. Congratulations, Dan, for this great initiative. I have 3 questions. So the first one is, are you going to assume that these Asian American individuals, they have enough knowledge about the benefits of endoscopy, or are you going to do an educational session? That's the first one. The second one is, are you going to take anyone, or have you considered doing an stratified sampling that you don't end up with just women, considering that women participate, now the participations are higher in women, right? And we see more women in gastroenterology departments. So are you going to balance men and women and potentially age, right? Because you are interested in prevalence. The third question is, are you going to collect any biospecimens, or at least are you going to ask the individuals about the possibility of willingness to provide biospecimens later, or to get some information about that? Because as you know, we really lack biospecimens, right? So this will be a good opportunity also to check about the feasibility of donating some samples. Thank you.
Thank you, Constanza. So the first question, I think we're gonna basically send a secure message through our Kaiser system to the patient. It's actually not perfect because they may not speak, say, English, the patient himself or herself. But based on our experience, if they have an active account for the email system, in email communication, usually they have a family member who can speak English to answer the question. So it's probably doable. Ideal way would be just sending them, in letter in Chinese, in Japanese, in Korean. It's probably going to be very hard to implement. That's a challenge, and also we need manpower. We need resources to help do that. I think the first step is going to be hard to do the study with that, those communication tools. The second question is that we have not thought about the details of how to recruit members. I would say men have higher risk of gastric cancer compared to women in general. I would say at the beginning, I would probably not only gonna just balance the men and women. I think we're just gonna just send out a batch invitation and see who is gonna respond, willing to be screened. The third question about specimens, we wouldn't take biopsy specimen anyway at the time of endoscopy per our standard protocol. But out of specimen, we can ask whether they're willing to share, for example, like blood samples and others. I think it's going to be something we can mention in a letter, but it's kind of like it's a little outside of this initial protocol. But I think we can definitely do that as additional component into our study.
Oh, sorry, if I can ask something else. Is there a possibility of adding an additional arm of individuals that they attend colonoscopy for a different reason that is not fit positive, or just as a comparison? Because as you said, this is a very selected group, right?
I think it's doable. I think I'm treating the screening as like a broad category. It could be screening average risk or even high risk. They have history polyps. They come in for colonoscopy. We also have this category of diagnostic colonoscopy. For inpatients, it's not possible because they have bleeding. It's not possible. But for outpatients, they may have just abdominal pain, where that can be considered. But I would say it's going to be a little complicating the picture because they have abdominal pain. Then that's suggesting something in his stomach area, or is it going to be like a symptomatic patient get screened? I think we can potentially add an arm, but I would say, yeah, it's a good suggestion, Constanza. I think I definitely, I think I don't disagree. I think to start the plan in a simple way, straightforward, make it feasible to do, we're probably going to start with screening colonoscopy, but that's something we can do in the field. Depends on the findings, I think.
Thank you. Dan.
Ask for NCI funding.
Can I ask you a question, Dan? Why did you need IRB approval to do this study?
It's a good question. We actually try to avoid IRB, so we submitted a research determination.
I mean, because the guidelines indicate for high-risk individuals, it's appropriate to get screened.
Yes.
This is standard care.
Yes,
I mean,
so we try to
why-
avoid
yes.
that. We actually submitted IRB determination about several weeks ago. That has still pending, so we try to avoid IRB because that's going to be like very hard to deal with in the protocol. But I would say this is, as you said, this is a quality improvement based on the evidence. So I hope we can bypass IRB process. That'll be a big win for us.
The reason I bring this up is because, some of the other discussion was about where's the large randomized controlled trial, whether it's H. pylori, whether it's screening. And to be honest, I don't think there's going to be one. I mean, let's just face it. But I think what there can be are pragmatic trials, right? There can be, now that we have guidelines, standard of care, different practices, and evaluate the outcomes. And so I think that's where there's an opportunity. And hopefully that's one of the reasons that we've been invited to have this panel is, of course, this is a great step forward, but ultimately what I think we'd all like to see is the large-scale study, but it doesn't need to be a traditional parallel group randomized controlled trial consenting every patient to undergo H. pylori testing or endoscopy. It's really, if we're going to achieve the kind of scales that we need to do this in a manner that is actually feasible and cost-efficient, then I think we lean on what's standard of care now.
Ernst.
Yeah, thank you very much. It's a beautiful, beautiful study to do this. So just following up on the IRB, I might try to give you another perspective. So now you do not go for the IRB approval because this is standard of care. After 50 patients, you stop. I'm a neighbor. I'm not in the study, but a year later, I'm diagnosed with gastric cancer. And then I come to you and say, why didn't I get the standard of care? And then you say, well, but this was a study. But then where is the IRB approval? So you'll get into potentially very difficult issues if you don't. If it's standard of care, it's standard of care for everybody.
I don't think you can publish that. So you would need an IRB to publish. Right.
Yeah.
Now, I would clarify that I wouldn't call it standard of care, acceptable care at this point, because it's not that you have to, there are guidelines that are saying it is mandatory, but it's acceptable practice. So,
Okay, and if I may, with one follow-up question, it's wonderful, Dan. Everybody asks you, so we're all excited about your study, and then everybody asks you for ways of actually, or suggesting to expand it, and you consistently say, you stick to the protocol for good reasons. Let me give it one more try. So we hear about all the questions and the issues about uptake and about the actual findings that you. I would be interested to say for all your populations, and you subspecify them in the Kaiser Permanente, what would be the uptake and the helicobacter rate and the atrophy and metaplasia and dysplasia in the people with a Latin American background? What would it be in your African American background? So why not consider if it's only 50 people per subgroup, why not do 6 times 50, it's still a relatively small study, right?
That's a great suggestion. It's more like a bandwidth issue. This is like almost like I don't even know this is going to be going smoothly because we're very busy within our schedule. We're going to start with this. It definitely can expand. I hope we can expand 5 times, 10 times from this.
I'm going to take this as I completely agree with you, but I completely understand what Dan's doing, because what he is really taking is the highest risk group, right? And if this doesn't work in the highest risk group, he's probably going to abandon ship, right? And say, okay, this isn't working. But our hope, I think everyone's hope, is that Dan demonstrates that in this extremely high risk group, this is beneficial. Now let's expand to what we really think is the high risk group. But he has to first prove to his institution that there's going to be findings, and then this should open a positive study. Should open some eyes. The risk is the study will be negative and there won't be any findings, but we really don't think, based on the existing data, that's unlikely to be true. So I understand this. Yeah, and I think it's phased, and I'm sure in the back of his mind he has the next group of and the thoughts of expanding the study with Jeff's support. I forgot to mention that Jeff has the unofficial title of Chief of Chiefs.
Well, it's official. Jeff is the chair of chiefs of our gastroenterology in the region. It's official, definitely.
Yeah. Which means I have no budget whatsoever.
Spoken like any chair.
Hi, John Yang from Colombia. Thank you for spearheading this effort. I might have one more thing to add to expand your study, but I think that's looking at more like immigrants, how there could be heterogeneity within the immigrants. So you're looking at first generation immigrants, so did they immigrate when they're age 20, 10, 45, right? That also matters. And then another thing would be, I think we're learning that there's other epigenetic environmental aspects of gastric cancer risk. So if they immigrated earlier in their age, what type of diet they had. I mean, that might be a bit later on, but I think first of all, I think what's easy to do would be, when did they immigrate? And also, do they ever go back for any medical care? Because I know at least some Korean population, at least my parents, they go back for screening endoscopies or colonoscopies back to Korea because they just feel much more comfortable there. But that's another thing to add to like a questionnaire or like a survey. Yeah.
Great points. It's definitely, we're going to confirm the country of birth, and also we're going to add actually the age of in the U.S. and arrival U.S. and I would say the time of the U.S. residence, the period duration wise, and in terms of the going back to Korea, for example, for care, I want to make sure that they have never had endoscopy. There will be a clean cohort to start with, because if you've had an endoscopy in Korea, then you're going to change already remove the dysplasia areas, and we're not going to find a difference. I think we're going to just make sure they have never had an upper endoscopy.
Yeah, so those patients would be excluded.
Yes.
Yeah. Okay, last question, and then we're going to do pictures. All right, Shelja.
Thanks. Great job, Dan. Shelja from UCSD. So I also will not expand your study, but I think also within like this, you're going to have a very rich group of patients and have a lot of important data. And I think kind of building on our conversation before that, an upper endoscopy, you can diagnose a whole bunch of things. So also including in the outcome, things like Barrett's or other, high risk, even like other gastric polyps, like things that, incidental findings that wouldn't have been seen before, because that also helps with that indication. One other thing would be in terms of uptake, also exploring reasons for why patients who decline to participate, like if there is something that they, you're going to have non-response, that people just won't respond to it, but maybe even following up with like 5 different options. Was it transportation? Was it a cost issue? Concern about the safety of endoscopy? Because I think that will give you a lot of information then from an implementation standpoint later on in terms of breaking down barriers for patients coming in for endoscopy.
Shelter, that's all great points. Totally agree. I think maybe that's a very good suggestion. We probably just in our initial message, we're going to ask some questions. If you decline screening, what's the potential? What are the reasons? Right, costs, or anything else? and that will be help us to identify those barriers to screening.
All right. Thank you very much. Let's give a round to the panel. And congratulations, Dan.
Thank you very much for all the suggestions.